My name is Amy Blakely. I'm the Vice President of Behavioral Health for Empower in the Grove. And it's my pleasure to talk to you today about our telehealth program. And when we say that, we'll talk a little bit about what the definition of telehealth is, but just to get a feel for the audience, how many of you have experience with telehealth or telemedicine? One person. And what's your experience been? In what capacity? With our company? With Empower? Okay. Right. So I'm joined today by Ernest Jones, who is our Director of Child Wellbeing. And I want to tell you just a little bit about our organization. We've been around since 1994, formerly known as Intervention Services. Our roots are here in Central Florida. However, we provide services statewide. We are in the process of merging with a company called The Grove, which is a substance abuse treatment facility for adolescents. Our primary services are mental health treatment, psychiatric treatment, substance abuse treatment, and then we have roots in the child well-being or child welfare side, which includes adoption, some prevention and intake and placement activities, and case management as well. We serve more than 11,000 individuals statewide, and those are growing. Every time I do this presentation, I have to change that number. Primary funding sources has been in the past mostly a Medicaid population and a child welfare population. However, that's quickly changing, and we are moving more now into commercial markets as well. So we have contracts with Cigna, Aetna, Florida Blue, United, TRICARE, Humana, and moving more into that world as well. Not to say we won't still serve Medicaid and child welfare populations, but we're just adding on to the services that we provide. I mentioned earlier we're merging with The Grove. We're in the middle of that merger right now. It will be official in July of this year. And at The Grove, there's a 72-bed adolescent residential program for individuals who have addiction problems. So we take a lot of kids who are addicted to meth, opioids, doing heroin, those kinds of things. And right now, we are in the process of renovating that facility. And so we'll build it back up with a shorter length of stay clinical model. And that's probably a good year in the works for that overhaul of that program. In addition to that, we are inheriting The Grove's outpatient psychiatric and mental health treatment for individuals diagnosed with substance abuse disorders. They also have prevention programs that we're bringing on and just consolidating with the existing ones that we have at Empower. So I'm sure that the shortage of mental health practitioners in this country and in the state is no newsflash for any of you. I like to try to point out the second bullet, though, that just always astounds me when we talk about psychiatry. So it's estimated that it takes about 26 psychiatrists to treat 100,000 people in our country, and we currently have about 10 psychiatrists to treat 100,000 people in our country, and in Florida, we have about 7. If you whittle that down to child psychiatry, we have about 3. So 3 psychiatrists for 100,000 people. And that's a real crisis. You look in the news every single day and you see what happens when individuals have mental health and psychiatric diagnoses that go untreated. And it's not getting any better. If you look at the last bullet, the average age of a psychiatrist in this country is 55. So it's not a field that a lot of people are going into. That's causing us to broaden the scope of other practitioners, like ARNPs and physician assistants, even pharmacists. And we'll talk about that in a little bit. Some of the unmet mental health needs, and you guys know these stats, but it's always astounding to me. So 1 in 4 adults have a mental illness in a given year. That's 25% of the adult population. It's pretty astounding. 1 in 5 youth have severe mental health disorders in a given year. 50% of all chronic mental illness begins by the age of 14. That's the reason the early intervention is so important. And approximately 60% of adults and 50% of youth with mental health and psychiatric illness receive no services in the past year. And that's where the shortage really impacts us. What we decided to do at Empower, and we're 6 years in the works now with our telehealth program, we decided to try to conquer the shortages that we were experiencing in our psychiatrists and mental health practitioners and try to come up with a way to utilize technology to better allocate the resources and the capacity that we had with our practitioners. So that's exactly what we've done. One of the things that's been very challenging always is when you're working with individuals in rural geographical areas. So I don't know where all of you are from, but if you work in a rural area, you will know that it may be a 2-hour drive for somebody to get to a psychiatrist's office or get to a provider. So one of the things that telehealth does is it brings the service to the person wherever they are so that we can eliminate those geographical barriers and things like insufficient transportation, lack of money to get places, lack of ability to take time out of work or school to get to a practitioner's office. It also helped us really decrease our wait list. So I don't know about you and your particular areas of work, but if you ask for a new patient to get a psychiatric evaluation in this state, the wait list is typically 2 to 3 months before somebody can be seen. We felt that that was entirely too long, and a lot of terrible things can happen in those 2 to 3 months. We're very well aware of those. So our wait list was about 10 weeks, and when we created our telehealth program, we can see individuals in our psychiatric virtual clinic now between 0 and 2 days from when we get the referral. So in some crisis situations or emergent situations, we've been able to see individuals the exact same day that we get the referral. Behavioral health is well suited for telehealth because there's really no physical manipulations that have to be done like other areas of medicine. And so we really don't put hands on our clients when we treat them in the behavioral health world. So it really lends itself well to utilizing technology to deliver the services from a distance. I just want to back up and talk just a little bit about what telehealth means. So really, it's very simple, and there are a lot of different names, and there are a lot of different types. You'll hear telepsychiatry, telehealth, telemedicine, telemental health, not to be confused with mental telepathy. That's something very different. But the nomenclature doesn't really matter. The deal is we're providing healthcare services from a distance, okay? So we're utilizing technology to deliver healthcare to wherever the patient is. And we've come up with a variety of ways that we do that, and we'll talk more about those during the presentation. We have the ability to allow patients to be seen by their practitioners from their smartphones or their tablets or their computers. We also set up kiosks or spoke sites that are out in the community, and we will identify places in the community. We have kiosks set up at the health departments, at group homes, at faith-based organizations, at homeless shelters, at some of the CBC organizations. Wherever people are already going for other things is really a common place for us to try to build a spoke site so that people don't have to go to other places. We also partner with a large pediatrician practice in Brevard County called Pediatrics in Brevard, and we have a spoke site there. So patients that are already coming, parents are already bringing their children there, they can now get their behavioral health needs met there via telehealth. When we set up these spoke sites or kiosks, we typically use what we call a telehealth exam room. So it's just like an exam room that a psychiatrist or a therapist would be in if they were seeing somebody in person, only there's a big screen and they're being seen virtually on the computer. And we do use a real time video, HIPAA-compliant, web-based platform for our telehealth services. I like to stress that because I don't want people to think that we're seeing clients on FaceTime or Skype, because that's against the law, and it's not HIPAA compliant and secure. So we have put a lot of time and money into developing a very robust platform that we use that is secure and HIPAA compliant. There are different types of telehealth, as I was mentioning. The two that we're going to talk about are the hub and spoke, which I just talked about. So our hub is a place where our practitioner is. Most of the time, it's from the practitioner's own home or private office. And then the spoke is wherever we identify in the community to put a computer in a telehealth room that's secure so that people can come in and be seen there. Oftentimes, we will staff those spoke sites with case managers who will assist individuals in coming in for their appointments, check them in, collect any co-pays if there are any, schedule follow-up appointments. So we'll staff some of those spoke sites to ensure that the experience is good and smooth for the clients that are coming in and there are no technology problems. The other type of telehealth that we provide is called direct-to-consumer. So back in 2014, Florida Medicaid started allowing the use of telehealth. And they allowed certain services to be reimbursed just as if they were conducted in person. It's called parity. And Florida Medicaid allowed us to do that way back in 2014. Florida Medicaid was actually the leader in Florida to start reimbursing for telehealth services and behavioral health. I never really thought I'd say Medicaid was ahead, but they really were ahead and have been cutting edge with regard to telehealth. So that was back in 2014. However, they said, we're going to let you do this virtually. However, we want you to use only the hub and spoke configuration. So our practitioners still had to come to our offices, and we had clinics speckled about Central Florida. They still had to come to our offices, and then we would put spoke sites in different areas in the community. So the patients or clients would still have to go to a spoke site. So it was better, but still not great because our clients still had to go somewhere. In 2016, because our project went so well, ACA decided that we want to move to a direct-to-consumer model. That's super exciting. To me, that's a game changer because now we're able to provide services to people in the convenience of their own home. They don't have to go anywhere. So we literally, from start to finish, have a system wherein somebody can go online, sign up for services, get their appointment online, be seen from their home phone or their smartphone or their computer, get the service they need, and have their medications delivered right to their address within 24 hours at no extra cost to them. And we'll talk more about the steps along the way, but that's the end game. The end game for me and for Empower is that we can reach individuals wherever they are in a timely fashion so that we can prevent mental health and psychiatric crises. There are other types of telemedicine or telehealth also. Store and forward. Those are used a lot by radiologists. So that might be, the X-ray being done and being sent somewhere for a radiologist to read. That's a form of telemedicine also. It's just called store and forward. Then there's something called asynchronous telemedicine, and that's something that we're very interested in, that's coming down the pike, and this is also a way that we can help bridge gaps in services due to shortages of practitioners. So the way that may look is we would have somebody be interviewed through a video, and it might be a psychiatric patient that's being interviewed by a mental health clinician. And it might be asking them all of the questions that build a component for a psychiatric evaluation. And even though the psychiatrist is not there and not available, that video may be recorded and sent to a psychiatrist for evaluation and diagnosing. That is not something that Empower does, but that's something that's being used in other areas of the country. Florida is very far behind with the use of telehealth and technology, but out west, like in New Mexico, Arizona, some of those very rural areas, they've been using asynchronous telemedicine for quite some time. And actually, when I talk about the roots of telemedicine, the military and the VA are the founders of this. So the military has been using telehealth for almost 50 years. And so they were utilizing equipment to try to deliver services to their troops when they were deployed out of the country. So they really have been the leaders in our country of the use of telemedicine. And then the last type of telemedicine that you might hear of is remote patient monitoring. They're doing a lot of fantastic work with that, with stroke victims or individuals who have the propensity to have cardiac problems or hypertension, those kinds of things, so that individuals can be monitored, and they're literally monitoring them from wherever they are out in the community, and they can detect and see when somebody's headed for trouble, and they're able to get that person into a practitioner for services before a crisis occurs to try to prevent cardiac arrests and strokes. So that's very interesting, just to give you a little background on different types of telehealth. So back to our type of telehealth, again, the hub and spoke configuration and the direct to consumer, where we're providing services to the person in their home through their own device. In 2013, we started with a pilot project. So we were seeing clients from a group home in Central Florida called The Haven. It's a shelter, and I think they've got about 40 kids there. So when a child is removed from their home, they would go into The Haven in a shelter status. And many of them had psychiatric and mental health needs that were unmet because there were no practitioners around to see them. So they were piling all of their kids into a big white van and driving them from Brevard County over to Osceola County. And they would get 8 or 9 of them at a time, take them out of school, drive them over to our psychiatrist's offices, and they would sit there all day and go in one by one to see the doctor. That does not work. And when you have children with psychiatric and mental health problems to begin with, sitting in a waiting room for an entire day, you can imagine what type of behaviors they would start to exhibit. It was just unfair, and it didn't work. We decided to put a spoke site in the Haven home. We thought, what a perfect opportunity. Let's put a spoke site right here in the Haven home. These children aren't going to have to get in a van and go anywhere. They're not going to have to miss school. They'll be able to just come in upstairs in the telehealth room and be seen by their practitioners. So that's exactly what we did, and this was our first pilot test. When we developed the pilot program, it was my job. I was a telehealth consultant for Empower for about 4.5 years before I came on board as the VP of Behavioral Health. And so I developed the policies and procedures. I did a lot of work with the American Telemedicine Association. I wanted to make sure that we had good quality practices around the use of telehealth because it was so new, and there are so many people that are skeptical about it. So everything that we do is HIPAA compliant. I already mentioned that. We then set out to train just a small group of psychiatrists during our pilot project to start using telehealth so that we could work out the kinks, answer questions, make it better before we replicated it across the state. We also went live in March of 2013, and every policy and procedure and every practice that we do is well aligned and in compliance with the American Telemedicine Association. This was a very memorable day in my life because it was our very first telehealth visit, and we did it with a little girl we'll call Allie. But she was at the Haven home, 9 years old, and she was outside playing basketball. They called her in, took her upstairs. We sat her in front of Dr. Cynthia Higgins, and she was able to have a psychiatric evaluation within 2 days of the referral being made. So, Since we started utilizing telehealth, we have conducted over 120,000 telehealth services. We have closed down our bricks and mortar clinics throughout the state, and we are completely virtual. So all of our practitioners work from their homes or their offices, and all of our clients are either seen from an established spoke site that's monitored by us, or from the privacy or comfort of their own home or work. We see about 800 telehealth clients per week now, and again, that's a number that grows every time I do this presentation. And we have over 50 practitioners that are utilizing only telehealth to provide services. Those 50 practitioners are board-certified psychiatrists, psychiatric ARNPs, psychiatric physician assistants, regular physician assistants, and then all of your master's level clinicians, your LMHCs, LCSWs, LMFTs, and then your registered interns that are providing services through Medicaid. We have been able to create, through the use of our telehealth platform, what we call virtual treatment teams. So, and I'll talk about this a little bit more, but more than one person can get into the virtual treatment room, if you will. And so we're able to have our psychiatrist, our therapist, our case manager, and the client all together in the same room, having a real treatment team. We're really excited about that. A lot of people say that they do collaborative treatment. Nobody really does because of logistics. It's not that people don't want to. It's just really difficult, especially when you've got 4 people in 4 different parts of the county or the state. So the telehealth services that we provide currently are individual therapy. We do family and group therapy online. Again, because of the ability for us to use a multi-treatment platform. For example, we had a case just very recently. It was a child who was being reunified with the parents. The mom was in Miami, the child was in Osceola County, and the dad was in Puerto Rico. And we're able to do family work through our telehealth platform. We also do behavioral health assessments and psychiatric evaluations and ongoing medication management. We have a lot of opportunities to use our telehealth platform in the child well-being arena, and Ernest is going to talk to you a little bit more about those in a few minutes. The multi-participant platform allows us to have family members, practitioners, guardian ad litems, case managers, anybody that has a need to know or wants to be involved with the appropriate consent, obviously, can be invited to the visit. So we utilize a secure URL link, and it's as simple as if I wanted to invite one of you to participate in a session that we're having with the client, I would send you a secure URL link to your either your phone or your email, and you would click on it, and it will let you'll get a unique identifying number in a separate text, and you'll be able to click on it and get right into the room entering that code. So you're able to join. It's that simple. And then as soon as that visit is over, that secure URL link goes away, and it's never used again. So it's a one-time thing. Again, we feel this is pretty cutting-edge stuff because we can really collaborate with the other individuals that have an interest or have important information that needs to be shared and part of a collaboration in our treatment. Likewise, we've been able to have treating practitioners in the medical arena work with our behavioral health staff. So everybody knows the big gap between medical health care and behavioral health care. There's a huge gap that nobody seems to be able to bridge very well. And we've been able to do that through the use of the platform. So we literally have our psychiatrists, a neurologist, and a pediatrician all on the platform together consulting about a complex child that we may be serving. And so that's really exciting for us. And I think that more and more practitioners are recognizing the benefits of being able to utilize this type of technology. Some of the diagnoses that we treat, first of all, we treat any DSM-5 diagnosis. I just cut out the top 10 that we see. And they're your basic things like ADHD. We treat about 60% children out of the 11,000 I mentioned. About 60% of those are children. And so ADHD is our top diagnosis. But we also we see a lot of bipolar. We see a lot of depression, PTSD, especially in the child welfare side, for those individuals that have gone through so much trauma. We have a lot of victims of human trafficking. So we have a lot of trauma-based services that we provide. Oppositional defiant disorder, and I think I already said anxiety disorders, but those are our top 10. But again, we treat any DSM-5 diagnosis. All right, so when and where? When and where do we do this? So in the past, when we required individuals to come to us in our clinics, we were very limited in the amount of time that we had during the day to provide services. Everybody knows, Monday through Friday, 9 to 5. Well, most psychiatric and mental health crises don't occur Monday through Friday from 9 to 5. So we were able to really broaden the hours that we can provide treatment with the advent of telehealth. So right now, our evenings go up until 8 or 9 o'clock at night. So Monday through Friday from 8 a.m. to 8 or 9 p.m. And then Saturday from 9 a.m. to 1 p.m., we can provide psychiatric services. As I've already mentioned, individuals can be seen from work, home, or wherever they may be. And believe me, as crazy as it sounds, we have individuals who take a break at work, go to their car, start up their engine, put on the AC, and see their practitioner from their smartphone in their car. As long as they're not driving, they're not allowed to be driving. You'd be surprised sometimes. But they're able to keep their appointments that way, and it's not so much of an inconvenience. And what happens when they're able to have a convenient way of seeking and staying in treatment, they actually do it. And certainly we're seeing a lot of that in our outcomes. But we also are creating a 24/7, what we're calling our virtual crisis response team, and this is getting really exciting. We were just meeting yesterday with a group in Polk County to talk about partnering with law enforcement and first responders so that we could be brought in as psychiatric and mental health providers at the scene of a domestic violence issue, for example. And we would be able to do some assessments and perhaps even some prescribing right on the spot to try to prevent hospitalization and or incarcerations. So that's really the crux of the issue, is it's all about access. It's all about trying to get services to the people when they need them so that they don't end up in our hospitals and in our jails. Equipment needed. I've already touched on this, but so many people say, oh no, I can't do telehealth. I don't really have the technology. All you need is a smartphone, an Android or an Apple phone, a smartphone. Anything with a camera will work. You have to have a Wi-Fi or internet connection. Or you can use a tablet, you can use a PC, just as long as you have an internet connection and a camera. It's really simple. And we have found, and I forget the exact stat, but I want to say it's something like 94% of the Medicaid population has a smartphone. So we always joke and say, well, you might not be paying your light bill, but you have your smartphone. Because everybody's on social media and everybody has their smartphones. So because we're able to use those devices now for people to access services, it's really been beneficial. I'm going to talk just for a minute about the Florida Board of Medicine. So back in 2014, our organization, Empower, was given special permission by the Florida Board of Medicine to prescribe controlled substances via telehealth. So make no mistake about it, we are not prescribing any narcotic medications at all. So when I say controlled substances, we're talking about stimulants for ADHD and anti-anxiety agents. So I don't want people to leave here and say, wow, Empower is just prescribing narcotics over the internet. We're not doing that. And we've had that question asked a couple of times. We're not pill pushers, and we're not establishing online pill mills. But our practitioners are able to prescribe controlled substances via telehealth. And we were granted that permission back in 2014, and the Florida Board of Medicine said, we will grant you permission to do this as long as you conduct some studies for over the next year, and here's what we want you to measure. And here are the outcomes that we presented. And it's really common sense kinds of things, in my opinion. So the very first one, clients are more likely to seek treatment because it's convenient. I can't tell you how many times I've had a person say to me, well, I was able to get treatment because I was able to do it from home. If I hadn't been able to do it after I put my kids in bed at 8 o'clock at night, I wouldn't have been able to take time off of work or school or get a sitter for my kids or get to where I needed to be for treatment. So because of the convenience factor and the confidentiality, people are more likely to seek treatment. And then the second bullet, if you're more likely to seek treatment, you're more likely to stay in treatment because it's convenient. It's easy for people to do. The cancellations and no-shows for our telehealth population is gone from about 49% in person to less than 10% when we started using telehealth. That shows you a lot. I mean, it's easier to keep your visit. You can do it from wherever you are as long as you're in a private, quiet, secure location. Also, the new evaluations I already mentioned. We went from an 8 to 10 week wait period to 0 to 2 days. That's humongous. I mean, nobody in the country can say they can do same day psychiatric evaluations. It doesn't exist. And in addition to that, we as an organization now, we weren't able to find psychiatrists to work for us. Now we have a wait list of psychiatrists who want to work for us. So I always say, I would venture to guess, we are probably the only organization in the entire country that has a wait list of psychiatrists to come work for us. And we have more psychiatric practitioners than we do clients. So it really turned the tables when we started utilizing telehealth. 98% of our patients have been satisfied with telehealth. Never once have I heard somebody say, hey, that was really easy for me to just do from home the other day, but I would rather take time off of work and drive across town on I-4 traffic and sit in your office for an hour to see my practitioner. It just doesn't happen. I think that we have to be mindful that is truly a cultural shift, if you will, in the treatment of behavioral health services. A lot of people, for whatever reason, may think that it's somehow cutting corners or it's diluting the quality of the service. And so people may say, well, my patients are never going to be seen on a computer screen. I mean, we've heard that a lot over the last 6 years. And I'll talk a little bit about some of the data that we've collected and some of the national data that proves those misnomers to be wrong. I also just wanted to mention, when we did our test for the Florida Board of Medicine, we had two groups. We had our control group, which were the patients that were seeing their practitioners in person, and then we had our experimental group, which was the telehealth group. So they were seeing their practitioners via telehealth. We collected a year's worth of data, and what we found was the telehealth group had 10% fewer controlled substances prescribed to them than the in-person group. Now, we attribute that to the fact that we're seeing people sooner because they're more likely to seek help, and they're more consistent in their follow-up appointments, so they're not going off their medications, they're not going into psychiatric and mental health emergencies because they don't have access to their meds. So I think that's very important, and we were really pleased with that outcome. We also had the opportunity to have University of North Florida conduct a longitudinal study for us. And we got some great outcomes from this too, and I won't bore you with all the details, but it was pretty fascinating. The three things that they really looked at were quality, access to care, and medication compliance. So as we already talked about, the quality of the service was not hindered at all as it was delivered through telehealth as opposed to in person. And I can assure you that almost every single research article that's out there in the United States will absolutely prove that the quality of the service is just as effective, if not better, than an in-person service. And that was really interesting to us and some of our psychiatrists as well, because, at the beginning, the psychiatrists were saying, I don't know, it's going to be too impersonal. I don't know if this is going to work, but, we'll give it a shot. And they were astounded at how much more open people were, especially our youth, because they don't want to see anybody face to face anymore. They don't want to go anywhere. They want to be on their phones or on their tablets. That's their age. They live in the technological era, and that's how they talk to their friends, and that's what they know. It's a comfortable environment for them to be in their own home or their own surrounding and have these conversations with their practitioners. Our medical director brings up a good point that I always like to share when I present. If you trace psychoanalysis back to the days of Freud, people would come in to see their therapist and they would lie on the couch, and the therapist would sit behind them and take notes because they felt it was less confrontational than somebody being right in front of you, sitting face to face, oftentimes with a stranger, and oftentimes talking about very traumatic and personal events. So we have been delighted to learn from our practitioners that they feel we have a more relaxed client and a more open client to disclose personal information because they're not as threatened. The access to care, we've already talked about that. We're taking healthcare to the person. So obviously there are increased opportunities for people to get services because we have this technology. And then the last is the medication adherence, and I've touched on that as well. It's the convenience and the ease with which they can have their follow-up appointments so they stick to their medications. Many times we know people end up in crisis situations because they're schizophrenic or they're bipolar and they ran out of meds. How often have you heard that? Ran out of meds. So if we can keep people consistent and stable on their medications, of course we're going to have fewer of those crisis situations that end up in hospitalizations and rehospitalizations and incarcerations. How do we prescribe? So all of our prescriptions are done online. We don't use paper for anything at Empower. We're completely virtual and electronic. So all of our scripts are done online through a software called Dr. First. That interfaces with almost every single pharmacy in the state. And we're able to prescribe right then and there electronically. And we also partner with a very large pharmaceutical group here in Central Florida that wants to piggyback, if you will, on our telehealth services. And so we have a contract with them wherein they will deliver the medications that we prescribe through their pharmacy to the patient wherever they are within 24 hours. So as I was mentioning in my introduction, we have a solution for individuals who can't get anywhere to sign up for services, get their services online, and get their medications delivered right to them. We have a lot of clients with anxiety disorders, agoraphobia. We have individuals with severe behavior problems who can't get out in the community, and older individuals who just don't have transportation or are not ambulatory to get around. And this has been such a great solution for them and such a great way for them to access services in their own homes. The pharmacy that we use will also help patients enroll in free and discounted medication programs. So when we started providing the direct-to-consumer telehealth services, meaning our providers are wherever they are and our clients are wherever they may be in the state, we thought, how are we going to collect blood pressure, pulse, weight, things that our practitioners may want to know, especially for kids, regarding their medical health before they prescribe and continue to prescribe ongoingly. So it was as simple as I was in the Publix one day and making my boyfriend, who has hypertension, sit at the little station and get his blood pressure done so I could see it. And I thought, wow, this could be something that we could use with our telehealth program. Lo and behold, we have partnered now. We have a contract with a company called Higgy, HIGI, and they build the biometric stations that you see in every public supermarket in the state of Florida. So the way this works is we may ask our patients to visit their nearest Publix within 3 days of their appointment, and they can go, we give them a unique identifier where they go in and they can enter a certain code which allows the Higi data system to acknowledge that they're an Empower client. And then when the biometrics are tested at the station, every single night we upload client data right into our electronic health record. So the next day or within a couple days when that client is seen by our practitioners, their biometrics are already there. So we felt like this is a really state-of-the-art solution. And we actually received some national press coverage out of Chicago for this innovation. How many of you have ever used a Higi station in your Publix? Yeah, they're in every Publix, and probably even more stores now. But we always joke and say, well, we don't care where you live, there's a Publix near you. All right, so some of the benefits, and I've already talked about many of these. One of the things that I want to talk about that I haven't touched on is just the increase in the practitioner selection because logistics and geographical constraints are no longer there. For example, if we have a Haitian teenage girl who wants to have a psychiatric visit with a Creole-speaking female psychiatrist, we have that. If the person's in Miami and the practitioner is in Tallahassee, so be it. It doesn't matter anymore. So when we've been able to add on our 50-plus practitioners, we look for variety so that we have a lot of bilingual individuals, Creole-speaking individuals, all different races, different ages, male, female. And so it really increases the practitioner selection for our patients. And we're able to utilize and better allocate those resources all over the state. Ernest is going to talk about this a little bit, but I'm going to steal his thunder for just a minute. It also creates a lot of consistency, especially in the child welfare system where we see that children are bouncing around from placement to placement, which we hate, but we also know is reality. Oftentimes they have to go and start all over again with a new psychiatrist, a new psychiatric evaluation, new diagnoses, new medications, new therapists, and they have to retell their trauma over and over to strangers. With telehealth, we can literally follow that child wherever they go. So if we have a good practitioner that's working well with the child has a good rapport with the therapist, that never has to be disrupted again. We've had children that start working with us here in Florida and have even been adopted out of state, and we will still continue to see that child. Had a child be adopted in Pennsylvania through our child welfare system here, and that child is still a client of Empower and is still getting services. We already talked about the medication compliance, but the stigma. Let's just talk about the stigma for just a minute. I touched on it, but it's so important, especially these days where people feel that it's a real weakness and it's something to be really embarrassed about to have a mental health diagnosis or need a psychiatrist. And so that prevents a lot of people from getting help. We also, because of that stigma, oftentimes we shy away from trying to get somebody to go get help because it's just the connotation of it is still so wrong in this country. It shouldn't be any different than having a medical condition, but it is, and we know that. Providing telehealth services is a way for somebody to remove the stigma because they don't have to be worried about being seen somewhere or being put in a van with 8 other kids and driven across the state to sit in a psychiatrist's office all day. That's not normal. That makes the stigma. That creates stigma. So we've been able to break down that stigma and create a real secure, comfortable, and confidential way for people to get services. And I'm telling you, we have a lot of individuals that say to us, I never would have gotten help if it wasn't for this method of service through telehealth. And I would have continued to suffer, and who knows what might have happened. It's pretty powerful stuff. All right. I'm sick of talking, so I'm going to turn it over to my partner, Ernest, our Director of Child Wellbeing, and he's going to talk to you a little bit about how we've integrated our telehealth practices into the child welfare services.
All right, thank you, Amy. And just real quick, you were pressing the keyboard, right?
Oh, yeah, the enter.
Yeah, okay.
I'm sorry. Yeah,
See, we didn't use the clicker.
Use the remote.
I'm good. Well, good morning. Still good morning. My name is Ernest Jones. I'm the Director of Child Wellbeing for Empower. Just to give you a little background, I've started with the company for about a month now. I'm from the child welfare world, which is when I noticed this platform, it just went off like a light bulb, because I've been in child welfare investigations for about 10 years, ended as a program administrator out in Lake County. So I've dealt with case management, PIs, so from the bottom up, GALs, the court system. So when this was introduced to me, I was like, well, this is kind of a no-brainer. It reaches so many kids in our system, and the integration that Empower had started, it fit perfect, and this was something that I can talk about and be behind. So let's just talk about the integration. A couple points that we're going to go through now that Amy has given you guys the platform of telehealth and kind of the background and how it can be utilized. I won't repeat some of the stuff she says through the slides. So it gave us immediate and improved access to care, right? And then within that, it flows right into our continuity of the provider, into our improved placement stability, and we'll talk a little bit about that, improved educational outcomes, and improved permanency outcomes. So these are some of the things that kind of get intertwined with Empower and telehealth. All right. So let's talk about eliminating the barriers. And again, Amy touched on some of this. Right away in the child welfare system, you eliminate the transportation need, because you can reach anyone in those rural areas. Coming from Lake County, we had a lot of rural areas. I'm talking about 2 hours to get to one county, one city to the other in the county, and Astor, Umatilla, all those areas where it really was a small community, and you would have to probably come to the major cities like Leesburg or Claremont or anyone, those areas, which was like a 2 hour and a half drive. This eliminates transportation needs, waiting times. Like Amy said, those kids in the waiting room, you're waiting to see your therapist or your psychiatrist, and you're just sitting there waiting, and you have a child that needs, how are they going to act in waiting rooms, and so you have that whole aspect. The stigma, she touched on that, so I'm not going to go into that, but it's pretty self-explanatory. Like, again, when I was reading some of these, and like, yeah, this is just, I'm not understanding why more people aren't doing this. The wait list, again, we have more therapists and on our wait list than we do clients. And there's plenty of clients that we can serve. Stability, and I'll, again, go into a couple slides about that and what that means in regards to permanency as well. Increased participation, she gave you the stats on that. And again, these are just things that kind of are no-brainers. All right. So we talk about the immediate and improved access to care. Eliminated the wait list equals elimination in service, gaps of service. So one of the things that my CEO brought to my attention with this was, okay, we're not trying to replace the traditional way of getting care, right? But there's so many gaps that this is a need, right? So if someone wants to keep their same therapist, they're saying, but let's say a case manager, I'm again talking in the child welfare world, case manager, can't get this child to an appointment or something happened within the traditional way, you can call up Empower or have a telehealth for that session, and we will relay the information back to their regular therapist. Like, these are just things that we can do to fill in the gap, because in the end of the day, I'm all about that child, right? Doesn't mean you have to compete with companies but we need to get this child serviced. And this child is going through gaps, and they need their medication, or they just need to see someone, and we can fill that gap for them. Increased pool of mental health, behavioral health services. She went through that. Again, I'm not going to touch on all of them because, you kind of did my slide for me, right? Safety planning for transition and managing safety. This one was a big one for me because, and I think I talked about it a little earlier, but I'll go into it now. When we talk about reunification, right? We reunify a child with their parents, mom, dad, or whatnot. That doesn't mean that the services that we provide stop because, obviously there was an issue there in the family that we had to take the child in the first place. So all those appointments that they've made with their foster home or their group home, and they're trying to get reunified with the family, the parent can pick this right back up. The kid doesn't have to, and again, you're placed in 2 counties away. Now you're going back home. They can keep the same therapist, same treatment, just like they would if they were at that place because it's all telehealth. All right. So the continuity of care, pretty much these are our providers, right? They're able to share information, able to put it all together, to use that information, to share the information, which increases the continuity of it, which leads right into our improved outcomes, right? So you have a sense of relationship building with that therapist because you're still with the same person. You don't have to change therapists. And with children, those relationships are important. And we know that when those kids are in care of those folks that they come in contact with, if you keep disrupting it, or just those ones that they can talk to, or, medication or whatever they may need, those relationships are important with those people that they continue to have those with, that you shouldn't be breaking up because we're trying to be trauma informed, right? So we talk about that a lot, but we try our best, but we know within our system there are things that we can't control, but the things we can, this gives us the opportunity to do so, which leads into our improved information sharing, which I touched on again. Amy said again, we don't really have those team conferences. Everyone tries, but getting everyone on the multi-platform so they can all talk to each other about this child, all see each other, all have that in real time instead of sending it to this person, waiting on this therapist to looking at this person to look over the charts or whatever they may need. All this is happening at once, so we can get this all together and it's quick as possible. All right. So placement stability. We all know we have these things that when these children are placed that take away from these placements. So I'll just let you know, lack of services, meaning they may be that lack or how fast we get those services once that child is placed, right? One of the biggest things that disrupt placements are behaviors, delinquent behaviors, right? So you have a child that has these behaviors trying to blow placement, or not even trying, may need these services, but we can't get it to them fast enough because they're in our system. We make a referral takes 2 weeks. That's not good enough. Now kids blowing placement because they have all these behavior issues, all right? Increased diagnosis. They may need to be diagnosed, but we can't get that diagnosis in time to help that family. Now you have the child moving again, right? Which is most of the time how it happens. They blow placement, they move, but it's not particularly that child's fault. They may need medication, they may need therapy, right? But we aren't able as a system to get it to them fast enough. So going back to that continuity of care and funding solution. So how are some of these paid for, right? Through Medicaid, we have partnerships with managing entities who have funding for this, right? Through TANF or either GR funding for parents and caregivers. Because one of the things that usually occurs, right, when we remove children from parents, right, they lose their benefits. The child's gone. Those benefits come to us, to the state, right? So the parent's not able to get services anymore. So again, that helps with the reunification and permanency. When you're trying to get, how are you going to help a parent reunify with their kids? Because we all believe in this room, right, that families should be together. So because they were temporarily removed and we're trying to get them back as a family unit, you have to still service that parent or they're going right back into the same environment that you removed them from. So lead agencies do not have to utilize their dollars. You go straight to your managing entity. They have funding for this. All right. So the entire family unit is treated, which is enhancing, again, the reunification and permanency planning. All right. So with your improved educational outcomes, so again, you have therapeutic interventions, placement stability, and permanency, which all attribute some part to education of these kids that are in foster care, right? So we all know the stats. We all have, and I'll just read some off to you, right? Each child, every time they change a school, they're losing 4 to 6 months of education. And some of these kids move 2-3 times within their lifetime within foster care, right? So within the telehealth platform, again, and I'll go back to the slide where it all connects, right? Placement stability affects that, right? The continuity of the care that they're getting affects that. So all this is tying into their education, right? 75% of foster children are behind in grade level due to a study out of California. And this is just like, again, I've been in the child welfare system for 12 years, 13 years, and to even just imagine a kid blowing a placement for whatever reason, moving a home, now they're going to a group home versus a foster home, wherever they go. And we have now, I think, and do we have is everyone in here at GALs or no? No, not everyone. So you have the ESSA process, right? Which is basically in place to, within that child being moved, you have to have a staffing within 24 hours to place the child, have a staffing whether to keep them in their same school or change their school. So this is important coming from the federal government because they understand these statistics that when these children move, they're losing precious time, whether it's in their regular school or, it's just hard being a new kid anywhere. But when you add on that the stigma of being a foster child or needing medications or have the stigma of having diagnosis, all that ties into the education of these children, which is, we all should be focused on. And I know my predecessor who had this before, she was big on education because these things really matter with trying to get these kids out of foster care. All right. So permanency implications. I have a couple articles that I read over the week about this, right? So with the relational and emotional permanency, right? Basically, these are the folks that when these kids are in foster care, and we talk about permanency, we have all these staff and we have all these meetings, right? We only think about permanency in regards to where they are, right? But there's relationships as well that these kids have, which again, I go back to the foster care moves. Whether it's their GAL, their therapist, their teacher, a friend that they have, their parents, that they make these relationships. So when we move these kids or remove these kids, they've been there a month, 2 months, 3 months, and you move them again or they blow a placement, they don't have the same relationships with those people, which affects the permanency, again, behavior, and then it goes back into education. As far as telehealth, when we talk about our therapists, if that's someone they've had for a year, 6 months to a year, that's just one relationship we can keep intact, right? Amy said it. We had a kid adopted out of state, still have her same therapist, still have, so she may be going through, that permanency issue of being torn away from her foster home or those relationships that they made. Now, thankfully, she's within a family and she's doing well, but she's able to still keep that therapist or that person that she trusts all the way out of state. All right. So the direction that we're going, and again, Amy and their team have done some great things with the platform, which again, I'm still learning how it's used, what we can do with it, and it seems that the possibilities are almost endless. So in regards to the child welfare world, we have 5339s that children have pretty much their medical report. We're trying to partner with whatever case management agency or lead agency to where, hey, we have our therapists fill that out and access the FISFIN to upload that into the system. So wherever this child is, again, that's the information that stays the same from the therapist that follows them around. It goes in FISFIN, the tab. Anybody can see it. Anybody has access to it whenever it's needed. Completion of psychotropic medication tab. That's also a tab in FISFIN. I don't know if we have any FISFIN users in here, but it doesn't look like it's going away anytime soon. So there's a tab there that they also can put the medical that you can provide to the caseworker and put that right into the tab in FISFIN. Family Teen Conference platform. When we had our case management agency out in Brevard, Amy was, and I'll let you talk about that because you were here before then, about how they had those family teen conferences and it was participation. Everyone was there. Again, when you talk about having people in different areas of the county, Brevard, right? And for those who know, Brevard is a fairly long county. right? Rural in some areas, getting all those folks together on a family teen conference and all, talking about the same thing and moving in the same direction was pretty awesome. Virtual visitation. Again, our plan is we can't substitute CFOPs and, for case managers or PIs actually seeing people, case managers in particular. When they're doing their visitation, their 30-day visitation, however often they need to see them, there's nothing saying that they can't do more than the minimum, right? Doesn't mean that it might necessarily count for their visit, but, they're calling their clients anyway, right? They're trying to locate their clients. They're probably not documenting that as contact. Maybe they are, maybe they aren't. But there's nothing stopping us from doing virtual visitation. We have the platform, we have the technology, we have the equipment, right? Check in on your family. Maybe something's going on and the mom or dad may have to call the case manager. And again, this doesn't mean just kids in foster care. We have non-judicial as well, right? Cases. So this is something that we have the platform and we're able to use. We just need the opportunity to do so. Virtual crisis response team, similar to her 24-hour response team, is something that, in the field of child welfare, she was talking about EMS and them automatically at the scene, calling up a therapist or using the telehealth platform to get that person evaluated or looked at, right? So I'm thinking more along the lines of if they're already involved with us and something's going on, hey, I need a meeting right now. I need a team conference meeting right now where that person can contact their therapist and contact us, Empower, and have that crisis response team available. So again, these aren't in place yet, but these are things that we can do, right? So my biggest thing before I leave this company or this earth or whatnot is this, which really hit home with me. The in-field virtual consultation with CPIs is something that I really want to get started, whether it could be with CPIs or case managers, right? To the fact where they go out to a home and there's a need there, or they don't understand what they're seeing, where they can use their smartphone, because they all have smartphones, to call up the Empower or therapist and have them out there in the field with them, evaluating, or even passing on the service to the parent when they leave. Because what happens is when they go out, hey, I'll make a referral for you, get back to the office, make the referral, sits on their desk, or whoever they send it to, it may sit on their desk. They get another case, they're worrying about something else, everything, the day gets away from you, and then it's next week, and still haven't made it. What if we can go out to the home, smartphone in hand, hey, this is what I'm seeing, this parent may need that, or set it up with them right there. So when they're leaving the home, they already have a service and referral made for them while they're leaving the home. I think that's just a way to get out to the family quicker, get services quicker, to alleviate that need for possibly removal or, just prevention while they're out there. So we're really going to try to make that work. That's one of the biggest things that I'm going to work on while I'm here with this company. Again, the multi-observer feature, Amy went through that. Same thing, right? We're trying to get MDTs, and I guess we did have MDTs on there. But all this is occurring through a secure link. Again, it's not something that they're calling on FaceTime or getting everybody up on the three-way call. This is all through a secure link to where you can staff those human trafficking cases, right? Have to have MDTs by law. You have to have them, right? You have all parties all over. I remember we used to do them in Lake County. You had the sheriff's office. You had people in Orlando that had to be there, program office, everyone that had to be on these calls, or at the actual building. You had one, I forget her title, but she was a human trafficking law enforcement person that had to travel to all these counties in the circuit, to all these meetings, to the point where you couldn't overlap her schedule, right? Because she had to be here on one day and had to have him here on one day. And they would not budge from that scheduled meeting. I need one on Tuesday. Nope, your county is scheduled for Wednesday. Now it doesn't matter. All you need is a time. Everyone could be in the same room together. All right, and I'm going to turn it over to Amy.
Okay, thank you. And in the interest of time, I'm going to breeze through these last few slides, but it's important. How do we access services? Okay, so if we want to have a telehealth service, either psychiatric or mental health service, how do we access them? I already mentioned that everything is done online. So what we try to direct people to is our website. If you go to www.empower, spelled with an I, fl.org, then you will see two big buttons on the home page: refer myself or my child, or refer another person. You click on one of those buttons, whichever one's the appropriate one, and it will take you to a secure link that shows our telemedicine practitioners and platform design. It's a company called Mend, M-E-N-D, and it will take you right to a page where you just start completing demographic information. And it's not a whole lot of information. It probably takes about 5 to 7 minutes to complete it. And then you just click submit. And when you do that, it will ask you to accept the terms and give permission, if you will, to enter into telemedicine services. And then you will see if you do it with somebody's phone number, they will send a text. And it says your video appointment with Empower is scheduled Sunday, July 23rd. Use this link to confirm your appointment and use this link to get into the video session. We also send a series of reminders, which also helps people to not no-show or cancel at the last minute. So once the appointment is made, a text comes up like this. And then I want to say 3 days prior to the appointment, another reminder comes out. And then 24 hours prior to the appointment, another. And then at the time of the appointment, I want to say 5-10 minutes ahead of time, it will send it to you again. So that all you have to do is click on that link. There's a 6-digit code, as I said, that would need to be entered along with the person's birth date. And that's what makes it HIPAA compliant, so that we know other people aren't getting into it. This is an example of what it looks like if somebody signs up through an email and they get an email that looks like this. You probably can't read it all or any, but it basically just says your appointment's scheduled. Click here to test your system. We recommend that people test before the appointment, and we have case managers and telehealth support specialists that help people do that to make sure that the connectivity is good before the appointment occurs. I just want to mention we've been approached a lot by other organizations that say, hey, Amy, can you come out and train my staff? We want to start using telehealth. We want to start a telehealth program. And first of all, the answer is no. We have been working on this for 6 years, and we are not selling our technology or our secrets to anyone. We are front and center, and we're the premier provider of telehealth services in Florida, and we've earned it. We're first, and we're here, and we want to be the premier company to do it. I'm just giving an example of the types of investments that we've made as a not-for-profit organization over the last 5-6 years. It's almost $600,000 we've invested. Where are we now? We already talked about the number of services that we have. We're partnering with law enforcement, hospitals, physician practices, universities, you name it. We've been very influential in Tallahassee on impacting telehealth legislation in this state because we don't have legislation or regulation around it as much as we would like to. We are impacting statewide HEDIS measures, so when people are discharged from the hospital and they have to be seen by a practitioner within 7 days and nobody can do it. We have a statewide solution for that via our telehealth program as well. And we are working to hire practitioners statewide and bring on more and more innovative contracts and pilot programs throughout the state. I'm going to end with that. We've got about 6 minutes left. And I'd like to open up the floor for any questions that you may have for either Ernest or myself. We'll start in the front row. Yes.
How much treatment are you guys doing for dual diagnosis?
Yeah, we have quite a few clients like that. As a matter of fact, my background for the first 10 years of my career was working with developmentally disabled individuals. I ran the hospital at Devereaux, and so I oversaw the Center for Developmental Disabilities there. I'm very, very familiar with that population, and we do have several psychiatrists and mental health practitioners that work specifically with that population. So we absolutely treat those individuals. Oftentimes, I just want to add, when you're working with people with intellectual and developmental disabilities, you will need somebody probably who will be a support person or a more reliable reporter sometimes than maybe the person themselves. We also have spoke sites in developmental disabilities group homes where we're seeing those patients because they're often so hard to get out into the community and sit in waiting rooms. But we absolutely serve that population. We have a spoke site at a company called Quest, and they treat a lot of adults and children with developmental disabilities, so we partner with them. Yes, second row.
Yes, what's the average consultation time or average time spent with the client?
Okay, for psychiatric evaluation, it's just like in person. Psychiatric evaluations, 45 minutes. Medication management follow-up is 15 to 30 minutes. Intake for mental health counseling is about an hour. And then therapy sessions run about 50 minutes to an hour. Same as in person. Yes, ma'am.
Questions. First, do you have minimum age for the people?
We treat 5 and up.
Question is, have you all looked at whether your therapists stay with your company longer than traditional models that they would? Because that's one of the inconsistencies we feel out of as well, where they're saying that the kid is moving places.
But the therapists are rotating. I will be very candid with you and say that we have had a lot of turnover when we implemented telehealth because a lot of therapists just don't buy into it. And it is, as I said, it's a culture shift in the way we deliver services. But the interesting part is that we have gone through that now, and we are bringing on some therapists who have some unbelievably innovative ideas of how we can work with children via telehealth. And I'll give you a real quick example. Play therapy. Well, we do play therapy and we can't do play therapy online. Well, yeah, we can. And guess what? Our telehealth platform provider is working on interactive types of games and things that we can do to actually play games or watch children engage in game playing. We're having something built called a virtual resource toolkit that allows us to have interactive participation during our therapy sessions. So we are coming up with, and pretty cutting edge stuff, ways to utilize play therapy online. Yes, ma'am. Not specific to that population. However, I can assure you, because I worked in that field for so long, I can assure you the access that they get by having this virtual solution really assists them in getting the medications that they need and staying on those medications without having to take them out into places into the community where they may be uncomfortable and have maladaptive behaviors. So just by virtue of, again, the consistency and the access for that population, I'm sure that the outcomes would be astounding if we looked specifically at that population. We have not done any studies on that yet, just targeting the IDD population. But it's kind of, I would be shocked if it didn't mimic what we already presented today, that the quality is just as good, that the access is better, medication compliance is better, and crises are fewer. Sure. Mm-hmm. Absolutely. Absolutely. We have to, depending on the funding, like we will treat individuals who have Medicaid, whether they're APD clients or not. It really doesn't matter. The group home that we have a spoke site at, the Quest site, obviously is very large in Central Florida. I'm sure you're familiar with it. We're able to bill their Medicaid for their services. Some of them are diagnosed with autism. There are times where we have to be creative and ensure that we document things a certain way so that that population can be served under our Medicaid guidelines. But we're no strangers to that. I've been doing that for almost 30 years now. Yeah. No, it is. It is. It is. Because they can be, absolutely. It's the future of behavioral health care. Mark my words when I say that. So people that are skeptical about it are naysayers. They're not going to have services available to them 5 years from now, because this is where this is going. There's no doubt in my mind, because I've seen it happen in other states. We're far behind, but I know where it's going. I think a lot of psychiatrists that have some experience with telemedicine or with us understand where it's going now as well, because it's taking off so much and getting traction. And so we have, for example, we have a psychiatrist who approached me recently and said, I have this office and I'm paying all this overhead for all the offices and record storage and all of my staff and scheduling people and software and computers. I don't want all this anymore, but I still want to see my patients. So why don't you hire me, Empower, and I'll bring over all of my clients, all my patients, and you take on the overhead, which is all virtual. It doesn't cost us. I mean, it costs us support staff, obviously, admin costs, but not bricks and mortar. So he wants to close down his practice, come on board with us, and see his same patients, but just via telehealth. That's the wave of the future. And I can assure you there are more and more psychiatrists that are wanting to do that. And that's, in the word's getting out. We present a lot to psychiatrists, and our psychiatrists are out there promoting us. So that's how we've established the wait lists. I get calls every week from psychiatric practitioners who want to work for us from all over the country, not just in Florida. Yes, ma'am. Mm-hmm. Absolutely. We are trying so hard to break the barrier and get into the schools. We do a lot of school counseling now. So we're in Osceola schools. We're in Seminole County, Brevard County, Polk County. I was just at a meeting yesterday in Polk County where they want us to meet with the superintendent. We just met with the superintendent in Seminole County. And I believe our CEO is meeting with Orange County superintendent today. But we are very, very interested in getting spoke sites set up in the schools. We all know the problem in this state with Baker Acts in our schools, and this is a real solution. So we've been asked by many different school systems to come and present because it is a solution to try to get people services. The Baker Act is way overused, and we know that it's oftentimes a way for kids to get out of school or teachers to get kids out of class because they're disruptive. So again, the shortage of practitioners does not help that situation. But if we were able to provide virtual crisis response, or we had a spoke site with ongoing services at that school, we can prevent a lot of Baker Acts. So that's a particular area of interest for me to do an outcome study on, because the baseline data is so terrible with the number of Baker Acts in our schools. I would love to have some pilot schools to implement our telehealth program in and then measure those Baker Acts. Okay. We provide psychiatric evaluations right now. We're not doing any other kinds of testing, but certainly if somebody presents with autism or intellectual or developmental disabilities, we have psychiatrists that are trained in those areas that would diagnose them for sure. Part of the psychiatric evaluation that we do ends with a formal diagnosis. So yes, we can do that. I knew that was going to be your question. So I'm a behavior analyst. I was one of the first behavior analysts in Florida, actually, when we used to take a written test, believe it or not, before it was even a national certification. So there's a lot of cool work that's being done in behavior analysis. We don't have that within Empower yet, but it's certainly something we want to do. And when we talk about remote patient monitoring, that's something that is very exciting to me, so that our behavior analysts are able to do parent training remotely. If a child's tantruming at bedtime, behavior analyst is allowed to see what's happening virtually and coach them through those types of behavioral crises that often lead to Baker Acts and those kinds of things. So there's some really cool stuff that's being done in ABA. That's not part of our program yet, but because of my roots and my belief in that, that's certainly something that we will be adding. Thank you all for coming today. Enjoy the rest of the conference and have a great weekend. If you are interested, thank you. If you're interested in getting more information or contacting us, please, I've got a sign-up sheet here. Just sign up your name, and then I'll have our marketing team contact you so we can try to do a presentation for your group or see if you have needs that we can meet utilizing our telehealth program. I'm going to put it right up on the front table. Thank you all.